All right, we are live. Thank you, gentlemen, for joining me. Today we've got the fantastic four surgeons, or four surgeons, three surgeons. We've got Dan Russouw, we've got Dimitris Tsekes, and we've got Rupen Dattani joining us. And I'm quite excited because this is something I'm passionate about. Anything that's upper limb related, that's my forte. And like I always say, this is the most complex joint in the body, and it's where all the action happens. And I think, other surgeons will probably try and fight this and try and, make it their thing. But I'm very excited to talk to you guys about everything shoulder related, everything elbow related, and everything wrist related in terms of injuries. But before I start, should we quickly go around the room and just have a quick introduction? So maybe we'll start from my top left. Dimitri?
Yes, I'm Dimitris Tsekes. I'm an orthopedic consultant. I specialize in shoulder and elbow surgery, specializing in both in sports injuries, but also pathologies like arthritis in the shoulder and elbow. I'm a consultant in St. John's St. Elizabeth Hospital at St. John's Woods, in Spar Hartswood in Brentwood, BMI Enfield Cavell, and in Highgate Private Hospital. And I am part of the Total Orthopaedics group, which through which we can provide with my other colleagues a fully comprehensive and specialist treatment in upper limb surgery. We have the ability to combine our efforts also with magnificent musculoskeletal radiologists and physiotherapists, and give a holistic approach to our patients.
Brilliant. Dan, I think you need no instruction, but I'll let you have it anyway.
Thanks, Rash. Hi, I'm Dan Russouw. I think I feel as though I've been around forever, but it's been amazing. I've started working just like you in upper limb at the beginning of my consultant career because I find it a fascinating joint, and the shoulder particularly, but elbow as well. And they are amazingly complex, but also amazingly gratifying joints to try and repair and get back to normal function. And I often felt that people ignore the upper limb because you don't walk on your arms. And historically, orthopedics has been lower limb centered, and I think we could change that for the good. I work with great colleagues in Total Orthopaedics, and my work is mostly shoulder in Northwest London.
Brilliant. Rupen?
Thanks, Rush. So, Rupen Dattani, I work with Chelsea and Westminster, and part of the Total Orthopaedics group. Like Dimitris said, within Total Orthopaedics, we can offer a comprehensive upper limb service, which ranges right from the shoulder down to the wrist. In terms of work, mainly arthroscopic work, as well as arthroplasty work. But what's exciting about shoulders is it's evolved over the last 10 years. So the procedures when I was training, which didn't exist, which now exist. And it's great to be part of that sort of faculty and part of that group community. We've just seen the involvement of sort of shoulder and elbow service.
No, fantastic. I think I'm gonna say it right now. Rupen almost operated on me, and this is a cool story because I'll delve into why I love shoulders. So I used to be a bit of a breakdancer back in the days, and I had a direct route to the orthopedic surgeon. So I've had 6 surgeries, and I think my 4th and the 5th surgery, they were both bilateral shoulder dislocations. So I think one of them we had it repaired very well, successful, and then the other one happened. And, I went to see this guy and I'm like, oh man, I really don't want the surgery happening. And, I was hoping that it actually doesn't go down the route of surgery. And actually Rupen turns around and says, look, you've got a good chance of actually working on conservative management, and then let me sort of take over over that period. And I think I spent 3 months rehabbing the shoulder, getting it stronger, getting it fitter. And I had a funny MRI come back, and he's like, I've seen this, but I haven't seen this so clearly. And what I'd done is I'd rehabbed it so well, or whatever I'd done was working. The area which looked unstable, I'd actually just created a whole lot of stability, and actually on the MRI it looked great as well. So Rupen basically just discharged me, and little did I know a few years later I'm going to be working with him. So yeah. No, it's fantastic. So let's dig in. It's COVID. Everyone's doing home workouts, and everyone I know is in shoulder pain. Does anyone want to start off? Maybe Dan, you can start off with what it's explaining what's going on here.
So people are doing peculiar things. I'm getting a mixture of people coming to see me now who have been sitting on problems they've had. And the biggest problem I've found is people have what they think is a trivial injury. And because there's COVID around, they just say, well, I'll rest it up. I'll wait for it to go away. I'll just, wait for it to naturally heal up. And people are tending not to seek the initial advice as they did before. I've had a lady recently, which just illustrates this, where it can actually be more significant than you think. Yeah. She had a fairly benign fall in the supermarket at the end of February. It was a February time, and just had persistent ongoing shoulder pain, which seemed to be cuff related. Seemed to be cuff pain. And she waited and waited and waited, and eventually decided, like, I need to get some help. And she managed to get herself an MRI scan, which showed an undisplaced braided tuberosity fracture. Okay. Now, they're slightly unusual. It's not a cuff, but it behaves like a cuff injury. And although she's in trouble and there's not much we can do about it, she's much happier that she knows what's going on.
Yeah.
So I guess my message is for people, there are people out there, able to just give you advice, simple advice, straightforward stuff. And I think most of these, if you call them minor, not major, they're not major injuries that we're picking up, can be, you can be rest assured and you can find out what's going on and you know what it is and you can make a treatment plan.
Yeah, totally. And I think one of the things that we're seeing is the spike in injuries related to shoulder, and this is probably exacerbated from an underlying condition that they may have. Dimitri, when it comes to shoulders and particularly the rotator cuff, a lot of people say, well, one of the things that really gets to us is the rotary cuff, the word rotary cuff, the grumbling shoulder. And it's our job, obviously, to correct that and help them out through this. But with the cuff itself, like, what are the things that you are seeing currently, but even pre-COVID, that you think people can start addressing way earlier on, rather than having that that last chat with you?
What I'm seeing currently is that people are they are away from the gym, so they're having lots of unsupervised training at home. Mm. If you check into Amazon or any other marketplace, you cannot buy anymore any bench. They're all starting bench pressing at home and utilizing wrongly their rotator cuffs and the shoulders, because they are doing it without any supervision, without anyone showing them how to do it. They are exercising without any balance or coordination. Mm. Sometimes they neglect doing their warm-up or their stretching exercises. They neglect focusing on the rotator cuff tendons first and then go on to bench pressing or other forms of exercise.
Yeah.
And therefore, by not utilizing properly the rotator cuff muscles, which are the major stabilizers of our shoulder joints, they start having impingements.
Yeah.
Start having, through our virtual consultations, I've seen patients having potentially rotator cuff tears. I've seen patients with pectoralis major, with pec major tears, okay. And they're starting having also inflammations around their elbows. So improper, imbalanced exercise without any supervision has starting to cause problems, in our population, and especially to people who are keen on having this conversation with their friends. How much do you bench? How much do you exercise? How much can you lift, etc. So.
Yeah,
I think there is going to be a spare of injuries that's going to come up quite soon after we go back to normality in our practices.
But one of the things that
and we need to address that through an holistic approach, through physiotherapy and maybe surgery sometimes.
Yeah, one of the things that you guys are doing, obviously, at Total Orthopaedics is still having access to surgeons, having access to specialists, having access to imaging. Do you want to take us through that? So you have an online service at the moment that's still available, right?
So yes, we do have an online service still available. You can still reach us through our website. We can do virtual consultations through a trusted doctor application. Through other hospital services, we can use Zoom consultations, which are, however, professional Zoom consultations, not public Zoom consultations. We can share documents virtually with the hospitals. And we can also do telephone consultations. When sometimes you have seen the patient virtually or face-to-face previously, you can basically give them a call and chat and see how they are doing with their rehabilitation.
That's fantastic.
We are keen on sending rehabilitation protocols through, leaflets, etc. And we keep certainly a rapport through patients. We allow them to contact our secretaries and ourselves as soon as they have an issue or experience something different.
Yeah, and I think that's the fantastic thing about Total Orthopaedics is the collective, the holistic view. Rupen, I think I've had the first-hand experience with you in the past, and one of the things that sort of comes to mind when I think of you, predominantly a lot of the time, is the sort of especially around the rotator cuff stuff. Where did your passion even start from? All of the sort of shoulder work and the rotator cuff work in particular.
I was privileged enough. I actually worked for Dan.
Oh, right.
Yeah, me too.
Right? I should have mentioned that. But that, I think with my personal fascination came, like Dan said, it's the joint that when you're training for orthopedics, people always thought upper limb, especially the shoulder, is quite complex, and people were shying away from it and doing a lot more, knee and hip, which is a bit more secondary work. And then you sort of found out that sort of arthroscopic work, especially towards the shoulders, was just evolving during my training, and people were moving away from doing open work towards arthroscopic work, and suddenly it became a lot more, amenable, and people's sort of expertise was improving, and you found that there was a lot more stuff that you could do, and you could rehab patients a lot quicker, having had arthroscopic work.
Yeah,
and because of that, sort of, it's fun doing sort of arthroscopic work. It's a combination of your orthopedic skills as well as your manual dexterity. So it's like playing a game. It's like playing a video game, and that's the way I see it. And the more you do of it, the better you become at it.
No, it's fantastic. And, what would you say to people who are always sort of complaining of shoulder pain but not wanting to access a specialist, or feeling that, it might always lead to surgery? I think one of the things that people think of surgeons is, straight away it's just going to be surgery, and that's the last thing I want. So I don't even want to entertain that conversation, or I don't even want to approach this person because that's what it's going to lead to.
I think that's it's a common misconception. I think especially with shoulders, I think the chances of you having a shoulder complaint and requiring surgery are very low. I'd say the chances of requiring surgery are going to be between 10 to 20%. So 80% of the time, if you have a shoulder complaint and you see a shoulder surgeon, you will be treated conservatively, and that's going to be through physiotherapy, and sometimes through injections, and sometimes through lifestyle advice, right? So one of the common complaints we see is people who work in the city, and now especially at home, they're going to be on a desktop, on a laptop. They'll be sort of hunched up. They're going to get sort of secondary impingement, shoulder-related problems, which don't require an operation. It don't necessarily even require any kind of intervention. It just requires some kind of ergonomic changes and help in terms of just posture. So just sort of basic kind of advice. And then you have another group of patients who pain's an issue, and so you try and get them over that pain through an injection and then rehab the shoulder.
Yeah.
And the chances of requiring surgery are very, very low. I think there's a few indications where patients will definitely benefit from surgery, but the rest of the time, I think people can be treated without surgery.
Yeah. Sticking to cuff tears in particular, at what point do people, when people come back from MRI scans, they'll either have either partial or complete tear, or, it doesn't really say the percentage or anything like that. And that's a good thing. I think sometimes people get worried about how much is it torn, what's the sort of millimeters, and they get really sort of bogged down on this, and they don't look at function, and they don't look at how they can prevent or how they can improve, or what access to help there is. In your opinion, Dan, when you see these people, what is the one piece of advice you like to give them? If they come with reams of Google Docs and say, "Here, Dan, this is what's wrong with me."
So it's a great topic, this, because I've come to the conclusion, having dealt with this sort of problem for a long, long time, that it's natural for rotator cuffs to tear as we get older. Wow. It's part of life. It's normal. So a lot of people who have, if you like, progressive slow tears on a failing cuff, which is probably the majority that I see, I sit down and explain to them that this is a natural aging process, and there is a changeover in function of the shoulder. A deltoid becomes the elevator, and the force couple of supraspinatus, of infraspinatus and subscap will take over the function of the cuff if you train it properly. And if that process happens gradually, there's a self-learning, and many people have cuff tears, as you know, and don't know about it.
Yeah.
And that process has happened. When there's a precipitating event and there isn't a chance to adapt, your shoulder function goes to pot. And so I spend a lot of time trying to explain to people, maybe this is not the end of the world. It's not a disaster. There is a way in which one can fairly easily get your shoulder working better. Now, as you quite right point out, people come with science, 3 millimeters, 4 papers, there's a partial thickness tear of supraspinatus, it's got to be repaired. And we're not helped by our radiology colleagues sometimes who will reinforce this message. Oh my God, we've got an ultrasound and there's a big tear in your cuff. You've got to see a surgeon and have an operation. It's quite difficult to turn those people around to look at, say, well, what is your functional requirement? What is the big problem? Is it pain? Is it function? Is it strength? And look at de-stressing the whole situation. And a lot of these people are very anxious as well, and anxiety, as we know, potentiates pain massively.
Massively, absolutely.
So gaining an understanding, looking at what there are other options, getting a degree that this is maybe not the end of the world. This is all partly a normal thing.
Yeah.
And if you say to people get bunions and it's not the end of the world, you can live with it, you can't. And you can often relate it to something other than this cuff tear.
Yeah.
So de-stressing the situation is important.
Yeah.
And as Rupen says, having gone through that with good therapy, pain relief, possibly an injection, you can help people get through without even considering an operation.
Yeah, I definitely agree on that. I think one of the things that we see when people come to see us is, they'll come with saying, "Okay, I've got this tear and I don't want to do anything to aggravate it or tear it further." And we say to them, we have to really reassure them and work through this. And then the other thing is, I don't want a frozen shoulder, or they've been misdiagnosed by either the GP or other health professionals saying, well, this is a frozen shoulder. So Dimitri, when it comes to sort of differentiating, actually, this is a question from Rajiv. How do you differentiate early frozen shoulder from a cuff tear or an impingement? So I guess he wants you to go through a whole analysis.
Rajiv was a very good, in making these nice questions and examining. I mean, to be honest with you, when the main difference between a rotator cuff tear and a frozen shoulder is the restriction in movement. So when you see the patient, they will always present to yourself with pain and limited range of movement. So you need to examine the patient and see whether this is a limitation in the active or passive range of movement. If there is limitation in the active range of movement, meaning that the patient cannot use his own force of his shoulder to elevate his arm forward or on the side, most likely there is a tendon tear, which is causing some issues. If, however, the problem goes beyond that, and even if you try to mobilize the patient's shoulder and that doesn't move, it is stiff, then most likely we are talking about the frozen shoulder. And frozen shoulder can happen from any injury around the shoulder, from any injury around the neck, even breast surgery, or even on patients with diabetes. It can happen with a very minor injury. So there are some red flags in our mind as shoulder surgeons that can direct us towards the appropriate, diagnosis. And then, of course, we have also the help of our radiology department, where we can utilize ultrasound or MRI scan, or even plain X-rays. A plain X-ray can show you if there is any problem with arthritis, let's say, which is restricting the range of movement. But the main difference, again, I might say, is that when you have a rotator cuff tear, you have pain. You have pain when you are trying to move your shoulder, even at the initiation of your movement. When you have a frozen shoulder, you're basically restricted. You cannot move your shoulder, you're frozen beyond a certain level of movement. However, sometimes that goes through a painful phase, then it goes through a freezing phase, and then suddenly, even though the shoulder is pain-free, you cannot move it.
Yeah. We call that the sort of the thawing phase, where we try and get in a bit of hands-on. And what is your take on hydrodilation? So obviously a lot of people do use this as a first-line approach sometimes. And what has been the sort of uptake on this, Rupen? Have you seen a change in how people are managing this now?
Absolutely. I think, again, it's one of those interventions that has evolved over a period of time. So when I was training, people were either told this is a self-limiting condition or you can have an operation. There was some bad press at that time about having steroid injections because, papers that were coming out through the literature were saying, well, maybe steroid injections don't work. I think hydrodilatation certainly has been a bit of a game changer, and it tends to work.
Yeah.
And it's mainly injecting high volume saline with some local anesthetic and a small dose of steroid, either under ultrasound or under X-ray guidance, straight into the joint.
Yeah.
And that's then coupled with physiotherapy. So I will, that would be my first line of treatment. So I'll say to the patient, have the hydrodilatation, and I tend to book them in for physiotherapy within 24 to 48 hours of having that injection.
Gotcha.
Now, what we're not very good at is predicting which patients it will do well in, whether they need 1 injection, 2 injections, or 3. So I tend to do 1 and then reassess them at 4 weeks, and if need be, you can supplement it with a 2nd and occasionally a 3rd. And I'll say anecdotally, it tends to work really well, and the number of patients who actually then subsequently require surgery is really reduced.
Yeah, and obviously the health conditions such as diabetes, hypertension, but diabetes in particular is a very big, strong factor in the rise of frozen shoulders. You know, where do you see this changing, or do you see people now understanding the link between nutrition, lifestyle, and physical injuries that they're coming and presenting with?
So there's a direct correlation between your diabetic control and your severity of your frozen shoulder. So if your HbA1c, which is an indicator of your diabetic control, is high, the chances are your development of frozen shoulder increases, and number 2, the severity of your frozen shoulder will increase.
Yep.
The one thing we have found is patients who have diabetes and have a frozen shoulder have a more stubborn form of a frozen shoulder. So they may not respond very well to hydrodilatation, but they may not even respond that well to an operation. So if they have surgery, an arthroscopic capsular release or an MUA, the recurrence rates are higher, and the range of motion may not improve as well as in a non-diabetic patient.
Yeah, perfect.
So it is a lifestyle thing. You have to be a diabetic control.
Yeah.
Diabetes under control, as well as having surgery.
Fantastic.
Right.
Dan, you have something to say?
Yeah,
Please do.
Just an interesting point. When I'm dealing with frozen shoulder, I try to again talk to people about the 2 aspects. There are 2 aspects to this. One is the limited movement, and the second is pain. They are interrelated somehow, because a stiff shoulder, for whatever reason, will give you pain when you force it to end of range.
Yeah.
But if your patient is clear that, look, the range of motion is not a big issue, but I just can't live with the pain, you're on a winner, because your hydrodilation and or steroid injections and or therapies, gentle stuff will be great, will help. There are some places where there are still aggressive people who try to regain range of motion by forcing.
Yeah.
And that I found is a very negative thing, because it produces more pain and increases the stiffness.
Yeah.
So you've got to respect this condition. It's a really nasty condition when it's bad. Yeah,
totally.
So I think your treatment for this is almost aimed at what your patient needs. And the alternative is true. I've had a couple of people have said, I don't mind about pain, but I'm desperate to get back to work, and my work involves lifting my hand up to put a switch going there. They can't afford even 4 weeks out of work. So you might tailor your treatment, and those are the people that I would very happily do a capsular release on early.
Got you. Yeah. And I think it's bringing back to the patient in front of you and the person in front of you. What are their limitations?
But I do find it useful breaking it down into its components to say, these are the things that are going wrong in your shoulder. It's pain. Pain is multifactorial. It's an inflammatory, it's also impingement, and it's tightness. But if we can get rid of that, would you be happy? And that's a good way to try and address it.
Yeah, absolutely. We're going to return to the gym, or the imaginary gym, as I like to call it. And where a lot of people are getting sort of front of the shoulder pain plus pec pain, or what we think is sort of pec related. What Dimitri, in your eyes, is the telltale signs to go and see someone, especially when it comes to front of the shoulder pain and the pec pain?
So injuries in the front part of the shoulder usually come from bench pressing.
Yeah.
And abnormal, basically, you haven't stabilized your shoulder properly to start with. You don't know how to do the exercises properly. You haven't been trained to do it.
Yeah.
So for example, in bench pressing, if you don't put your elbows exactly where you should do right under your hands when you're pushing up, you might cause a problem either at your elbows or your shoulder. If you don't stabilize your shoulder blades at the back of your bench when you're bench pressing again, you're going to cause problem around the rotator cuff.
Yeah.
So usually when we do gym exercises with these multi-gym nowadays, you know, at our house, we will get impingement.
Yeah.
And we will get pec pain. And you might get a tear. You might get tendonitis, which is small tears,
Yeah.
many small tears in the tendon. You might get a partial tear of the tendon or a complete tear of the pec major, where basically the tendon is pulled off its attachment from the bone. Now, what you will notice if that happens, you will notice bruising,
Yeah.
you will notice swelling, and you will see that you have lost your normal, the way your axillary fold is looking. It doesn't look.
It doesn't look right. Yeah.
Yes, it doesn't look right. So all these are signs that means that you might need to see a shoulder surgeon. And the reason for that is that if you're keen going to the gym, if you are an athlete, then you should get this repaired ideally within the first 8 weeks. There are studies that suggest that if this gets repaired, if you have a full thickness tear, if this gets repaired in the first 6 to 8 weeks, you have much better outcome than leaving it 3 or 8 months later on to go ahead and fix it. On the other hand, if you have small tears, again, you should see someone to teach you on how to do the exercises, how to do proper physiotherapy, how to reduce inflammation around your tendons, and therefore reduce the chance for a complete tear in the future if you continue doing your exercises wrongly.
Yeah, I definitely think that's the key. I think the one thing we always look at shoulders is load and how much load is going through the shoulder in whatever particular movement. And, you know, is the shoulder resilient, robust and mobile enough to handle that load? And people who are going to be returning back to the gym, I think with the one piece of advice we always say is, look, it's going to take you 12 weeks to return back to the weight you were lifting previous to going. But 9 out of 10 times people are going to go in and pick the same weight that they left off at in the gym, and then, you know, we are going to be busy, I guess, all of us are going to be busy trying to manage these injuries. But one of the things that sort of really frustrates me is obviously the technique side of things, but also when people ignore the pain until it's got to a stage where it has to be surgery and nothing else. And, you know, it's maybe 5 years of shoulder pain and they've accepted it. And then when it really goes bad, they don't accept it. And then they almost have this internal fight and external fight with all the health practitioners because of the time it's going to take them. Do you think people are have unrealistic expectations of what shoulder health really entails?
Sometimes they do have unrealistic expectations, and they have to understand their age. They have to understand that they have to accommodate to their body habitus.
Yep.
And they have really to realize that when they are feeling something bad about their shoulder or their body, they should speak to an expert. Yeah. Unfortunately, nowadays, because we're doing virtual consultations and we are seeing patients that have neglected going to their GP, have neglected going to A&E after an injury because they are in fear that they will overburden the NHS or that they will get COVID when going to a hospital.
Which is the next question I was going to come on to, but yeah.
We see them in our virtual consultations, and they've had a tear or a severe injury, sometimes a fracture for a month, and they haven't reached to any medical advice. And that's a real worry also.
Yeah. Funny you say that. We actually flagged a patient up who fell while walking the dog as part of the one piece of exercise. You know, they go out to walk the dog in the woods, and she tripped up, fell, and had a fracture, but wasn't ready to go to A&E purely for the fact that she's worried about COVID, and she's worried about and I know people, and there's news out there to show that there's 2 entrances to the A&E. There's COVID, and then there's the ones that don't. There's non-COVID. What's the advice to the general public? Because this is being shared almost on 6 or 7 groups, and there's a lot of walkers and hikers and people like that. Is the advice to go into A&E? Is the advice to kind of pick up the phone and contact you guys? What's the advice here?
I'd say if you think you've genuinely done an injury, then go to A&E and get that assessed, right? Like you alluded to, there are 2 different entrances to A&E.
Yeah.
The hospitals are still open to treat patients, right? So the majority of people coming through the hospital will be non-COVID patients who still have genuine health-related problems. So we're still seeing, people who are falling off bikes, they're fracturing their clavicles, AC joints. we've had distal biceps injuries, we've had olecranon fractures. These are genuine patients who have had injuries and they've been successfully treated. So we are still operating on people. So
Yeah.
it's not that you should ignore your health conditions. So the chances of you coming into hospital and having successful operations or non-operatively treated are very high.
Yeah.
You're not going to pick up COVID just by coming into hospital. So I would say don't ignore those. If you genuinely think you've injured yourself, then go and get that checked
Yeah,
out.
we've got a question from Kishan here. It's a great webinar. What would be the longer term effects of the coronavirus pandemic on elective upper limb conditions like frozen shoulder or cuff tears or any kind of rotator cuff work? Dan, is there is there going to be like a floodgate that's going to be open, and then you guys are going to be seeing a volume of patients coming through?
So I think you can divide this into sort of early, if you like, post-COVID. So over the next 6 to 9 months, possibly, and then in the real long term, so the next 10 years or thereabouts. So there is historically a little bit of information to help us with this. When a few years ago, well, going back 10 years, when we had extra long waiting lists, this was a similar sort of pseudo-COVID wait of non-treatment for people who had conditions. And we did find that some of these conditions could actually sort themselves out and get better. So we know frozen shoulder impingement syndrome, they often can improve by themselves and get better. But the contrast is true as well. The cases Dimitri described with pec ruptures, distal bicep ruptures, rotator cuff ruptures in younger athletic people are going to be terrible to treat because it almost certainly removes the surgical option. You can still try, but your surgery is on a you almost shouldn't try and even take it on, because trying to repair a 6 month or a year-old torn tendon that's retracted, the muscle is atrophied, is not a good idea. So you're looking at salvage management here. So I think that your point about actually, Rupen, is very good about making sure that if you do have a serious injury, you should get it seen to. You'll find you'll probably get Rolls-Royce treatment, because the orthopedic surgeons in the hospitals are going to be so pleased that they've got something non-COVID to deal with, that you are going to get A1 straight through fantastic treatment all the way. So I would really emphasize that if there is a serious thing that has damaged something where you're feeling this is really serious, I've done a major injury, get it seen to earlier, because delaying it is going to end up with a permanent disability.
Yeah, and I think people don't understand that, especially young gym goers. It's because I think they treat their bodies like Amazon Prime and they expect results straight away. And one of the questions from actually Elizabeth Ray is, can you explain to the watchers the importance of the adequate analgesia? She often has patients that tell her they don't like taking painkillers, and what's the how do you have this discussion?
Shall I pick that up?
Yeah, anyone can. Yep.
A pain relief is not just there for pain relief. It is, and as you guys know, because you deal with it more than we do, it's completely intertwined with function.
Yeah.
And around the shoulder, pain has an inhibitory reflex action, so it stops your cuff working if there's a painful shoulder. Your cuff doesn't work, you generate secondary problems causing bad movement, causing worsening pain, and you're down a spiral of pain causing bad movement, causing worsening pain, causing instability symptoms and labral compression. So it really is a bad negative effect to have pain. Yeah. And Elizabeth's quite right. Pain relief is a very important thing to getting the mechanics of the shoulder working better, and to get your head better as well.
Gotcha.
Because that anxiety from pain will generate worsening pain, amplifies your pain input in your thalamus. So you've got to have pain relief as step one, really.
Yeah, we've got actually a question specifically for you, Dan. You're a famous guy today. We've got one of I think a doctor, one of my friends, Minil Patel. People know him as the vegan doctor, as they like to call him on Instagram. His question is quite straightforward actually. What's the main way to prevent rotator cuff tears even in the aging process? Is it inevitable, or is it something that can be avoided, especially those who are doing strength training and resistance training?
So the general advice about warming up is good. Working within your limitation is good. listening to your body. So if you feel something starting to hurt a bit, back off until it doesn't hurt. It's much better to do a lot of repetitions of something that doesn't hurt and on a light weight than going to try and go big.
Yeah,
Now,
totally.
we say all of this, but we've all got testosterone and it doesn't work.
Nah, definitely. Sticking to distal biceps, and I know long-headed biceps injuries that can mimic themselves as sort of part rotator cuff, or that. Dimitri, what in your eyes have you sort of got a clear-cut way of distinguishing these patients and the advice to them? I know a lot of the rehab that we focus on is obviously getting the function working globally and as a movement pattern, rather than just focusing on the shoulder. We look at the whole person. When it comes to surgery for especially biceps tear or distal biceps, or just ruptures in general around the biceps region, how soon should they come and visit you? How bad can it get? And is it just aesthetics? Because a lot of people come to me and say, actually, you know what, I want it for the aesthetics. But is there a link to function?
Yes, there is certainly a link to function. And certainly, in Total Orthopaedics, we wouldn't operate for the aesthetic point of view. For the
Okay.
We would operate for the functional point of view, for the pain, for the cramping, and for the weakness that you will get after a biceps tendon tear. Now, our biceps is a very powerful flexor and supinator of our elbow. So we can flex our elbow, we can turn a key, we can turn a screwdriver, for example, with our biceps.
Yeah.
And biceps around the shoulder, it has two tendons, a long head that goes into the shoulder and a short head that goes into the thorax. In the shoulder part, usually the long head that goes into the shoulder ruptures. And if that happens, you can get the Popeye sign, where your muscle belly sucks down to your arm. You can get pain, cramping, loss of function, and bruising. However, your biceps still works because the short head, the other head is still intact. So
Gotcha.
not all is gone. So in cases of tears around the long head of the biceps, there are two options: either do a tenotomy or a tenodesis, which is basically fixing the long head around the area of the humerus using a percutaneous fixation method, and followed by rehabilitation, obviously. Now, if you experience a tear at the distal end of the biceps around the elbow, then symptoms are more severe. Then the Popeye sign tends to happen more proximally. Your biceps gets pulled up more proximally, and you get more weakness with regards to both flexion and supination.
Yeah.
In those cases, if you want to fix it, if you need to fix it, let's say you are an individual who is 80 years old and you have ruptured your distal end of biceps, I would really do through thorough discussion before offering them a biceps repair.
Yeah.
But for a young and healthy guy like you, Russ, which goes to the gym, it looks like, etc.,
Yeah.
I would offer them a biceps repair as soon as possible within the first few weeks after the injury,
Yeah.
because then the operation time would be smaller, the rehabilitation would be quicker, and the results would be, more safe after your biceps repair.
Gotcha.
And,
Yeah, and would you say with the biceps itself, I mean, what are the prevention ways? Obviously, gradual loading, building up your tolerance to everything that you're doing with the biceps.
So the most important, yes. So the most important thing is that always you have to take it slowly. So when we go back to the gym after the COVID situation, although if we are in the gym in our house, we have to take it slowly first and gradually build up our activity level.
Yeah.
We have to avoid improper posture and coach ourselves into the technique of how we utilize our biceps. We have to warm up before we start our exercises. We have to stretch our biceps before we do our exercises. We have to try to avoid lifting free weights using dumbbells, for example. And if we can use machines or bands to strengthen our biceps, in that way you have a more controlled strengthening.
And then you can progress
on your elbow.
Gotcha.
Heavy dumbbells and you're suddenly pulling themselves up. A sudden increased load is what can cause the tear in the tendon, not
sure.
a gradual, coordinated, balanced load.
Yeah, absolutely. So, Rupen,
pass this message to our patients through video links, through leaflets, through whatever measures we got.
Yeah, absolutely. I think one of the questions here is Rupen from a budding orthopod registrar, actually, and he's saying, moving forward, where do virtual clinics fit into practice post-COVID? are we going to be, is healthcare going to have this sudden massive change? Because, everyone's talking about this massive changes waiting after COVID and post-COVID. And I think we're so short-term in our view. We're not in the infinite game, and we're not thinking long-term. Do we think virtual clinics are going to be the new norm of doing a follow-up from a patient's comfort of their own home?
It's a great question, and the short answer is yes. I think, the days where, technology has evolved, so just like we're doing this webinar,
Yeah.
I don't think, I think initial consultation is the key. So I think the initial consultation where you need to be examined, I think will need to be face-to-face, because that's where you actually gauge the person. You need that eye contact. You need to be able to examine them to get the full picture of what's wrong with them. But subsequent appointments thereafter can certainly be virtual, right? So the days where you're waiting in the waiting room for 2 hours to get your MRI results or your ultrasound results or your blood test results, I think those days are gone. I think post-COVID, I think we're going to have those consultations where we discuss results virtually, treatment plans, just like you guys are going to be doing therapy online. I think lectures are going to be online.
Yeah. Do you think it is going to be an expectation of this moving forward? Especially with the length of time shoulders take to rehab. We know that, anyone who comes to see us with a small shoulder niggle can take up to 3 months minimum sometimes for rehab. And I think people have such poor expectations, and I feel like it's our responsibility, one, educate them, and then two, empower them to sort of achieve that at the end and go. Dan, one of the things that I always like and I've loved about sort of your approach is you're straight to the point, and you'll tell them how long it takes to rehab. And for some reason, when they see physios, a lot of the time it's the authority, maybe, I don't know what it is, but they think, it should have been fixed in 3 sessions. If I've had 3 sessions, I should have a reduction of pain by 30, 40, 50%.
I'm really glad you mentioned that, because it is one of the things that is peculiar to the upper limb, and that you can have a hip replacement and 6 weeks later you've forgotten about it.
Yeah.
You have a shoulder replacement and you're looking at 18 months, 2 years, 2.5 years before you reach its full potential. And that is part of the fascination why me and these guys go into shoulder surgery is it is so variable. There's stuff we still don't know about the shoulder. And I'm sure there's a lot of it still to be discovered as to why this variation occurs. It is interesting. Yeah.
I mean, it's taken us 45 minutes to get to the elbow, but I'm going to quickly touch on the elbow, and then we'll look at the wrist injury. So a lot of people are first putting themselves in push-up positions to try and do home push-ups, home workouts. We're seeing a lot of wrist-based injuries coming up. What's the sort of, the things that you guys look for, especially when it comes to wrist injuries? Like, when should someone come to see you guys?
So as far as wrist and elbow injuries are concerned, the calls I've been getting and the consultations I'm having over the last few weeks is basically from people being involved a lot more in gardening nowadays, a lot more in DIY nowadays. So they're starting to use their elbow and hands, in garden activities. They're starting to utilize suddenly their forearm using screwdrivers again and again when they didn't use their body is not built for this kind of work. And they are coming with pain around the elbow, especially inflammation around the tendons, the extensor tendons or in the flexor tendons. So they're coming with symptoms of tennis or golfer's elbow, even though they're not playing tennis.
Oh, trust me, there's a lot of frustrated golfers. They'd rather have a golfer elbow or a tennis elbow than have nothing.
And there are also people which are coming with inflammations around their wrist. So commonly we're seeing patients with inflammation of the extensor carpi ulnaris tendon, which is pain around this part of our wrist, especially when extending the wrist.
Yeah.
Or pain around the flexors of our wrist when we are doing this movement again and again. And the common advice is to start with some anti-inflammatory medications if they have no allergies and they are able to take it. Maybe use some splints, which can be provided nowadays through Amazon or through our website, the Total Orthopaedics, for example. Yeah. You have to immobilize temporarily, maybe your wrist or your elbow, and I always try to send them exercises, leaflets with exercises, stretching exercises and strengthening exercises, and obviously modify their activities. If gardening has caused this issue, stay away from gardening for 5 days. No. Your wife can do that, or your friends can do that, or your kids can do that. So,
The sacred message is it's a sort of period of rest. If something's aggravating that pain, don't keep doing that.
Yeah.
Stop, take a period of rest. Take anti-inflammatories as required, and then gradually return back to it. Pain's sort of your body's protective mechanism.
Yeah, for sure.
Stop.
Yeah. Yeah, and I think one of the things that we always say is, if it's not a 4 or 5 out of 10 pain, don't even complain about it. Keep working through and then see how you get on. And a lot of the times, this pain changes. We know from shoulder rehab that we actually use pain as a gauge rather than as a sort of a stop gauge and a start gauge. We actually use it as a marker to say, right, you want to get your tendon stronger. Let's get to that 3-4 uncomfortable out of 10 pain. Let's give it a 24-hour rest time, and then let's get back onto it again. And we look at volumes, intensity, and managing all of this in a very sort of tight-knit, very everything measured. And the great thing about nowadays is you guys have an app that helps with the rehab side of things, and so do we. And we get people rating their pain every day, and you can see a sort of a change in the graphs. You can see better function. One of the questions, I guess, again, another one from Rajiv: how effective is the shoulder replacement, and how long does it last? Wow, he's throwing these ones in the spanners, isn't he, today?
I'll go with that. It's a shoulder replacement. It's a great operation for pain relief, and I'll say to the patients, you have an arthritic joint. You lost your articular cartilage, you've got bone rubbing on bone, it's very painful. A shoulder replacement will get rid of that daily pain that you experience.
Gotcha.
In terms of movement, it's variable, right? You'd be surprised. You'll have some patients who will have fantastic range of motion, then you'll have others where the range of motion is not as great, but the pain's under control. So I'll always say to patients, if you're going to have a replacement, you want to have either a hip or a knee, because they do fantastically well. Shoulders, they're evolving, and now I think the results are improving. So there are two types of replacements. You've obviously got the conventional anatomic replacement, and then what's becoming more it's the reverse shoulder replacement, which is very popular. And if you look at the National Joint Registry, there are more reverse replacements being done in the UK and USA than a conventional anatomic replacement.
Yeah, can you just explain the reverse one for a lot of people who are probably considering this in the future? I think the anatomy and how it changes, because I think they obviously don't have that understanding.
So with any replacement that we have, what you need is your functioning muscles to allow that joint to move, right? So, for example, if you have your knee replacement, you want the quadriceps to be intact. Then hip, you need your abductors to be intact. Similarly, with the shoulder, you need your rotator cuff tendons to be intact in order for that shoulder to function. The problem is, as Dan alluded to earlier, as we age, not only are we going to develop arthritis, but you're also going to develop a problem with your rotator cuffs. So you're now stuck with a problem where you don't have an intact rotator cuff and you have arthritis. So an anatomic replacement, where you're literally replacing the ball with the ball and the socket no longer can work. So then you have a reverse replacement, whereby you essentially reverse that shoulder. So you're turning the glenoid into the humeral head, and you're turning and vice versa, right?
Yeah.
And the way that works is it works in anterior deltoid, help elevate the arm, and that's the way the reverse replacement works.
Gotcha.
So there are more reverse replacements being done purely because of the cohort of patients we're seeing, really elderly patients over the age of 70, who've got both a rotator cuff tear and arthritis.
Yeah, I got you. I think we've got so much to talk about, but I think this is where we maybe have to end it short and maybe start another one, maybe sometime along the lines. We may have to get very specific with each condition. I think that's where shoulder gets so interesting. I light up when a shoulder patient comes through, and I'm like, you know what, thank you for being in pain and thank you for coming through, because I'm actually getting bored now. So brilliant. And I'm guessing you guys are the same. Thank you once again for joining us today. I think it's been brilliant. How can people reach out to you guys, and where can they find you in terms of location? So we'll start with Rupen. Where can people find you?
I'm still working in Chelsea, Westminster. We're Highgate Hospital, BMI hospitals, but I think the best way to, at the moment, is virtual consultations. So through the Total Orthopaedics website, phone numbers on there, contact details are there, emails there. So
fantastic. Dan?
Yeah, I think same. I'm around North London and Spire, Bushy, and One Hatfield, but I think we've got a coordinated website, people manning it, so going through the website is probably the best place.
Fantastic. Dimitri, is this the same?
I'm also working in St. John St. Elizabeth, in PMI Cavell, at Highgate Hospital, and at Spar Hartswood. However, through our website, you can find us. You can have video consultation with us. We are affiliated with many applications like the Trusted Doctor or the Zoom Pro, or through Doctify. So people can easily reach us, and they can make online bookings, and they can have virtual and safe virtual consultation with us.
Fantastic. I think that wraps us for today. Chaps, go and have a great Saturday. Enjoy yourselves, and make most of the beautiful weather that we've got going on.
Thanks, Rush.
Thank you.
Fantastic. See you guys. Take care. Be safe.
Bye.